Thank you, Leo. And thank you for inviting me to present our study. So you mentioned the title already. The 21 gene oncotype DX breast cancer recurrence score assay is offered to eligible breast cancer patients irrespective of BRCA status. Recurrence score distribution in BRCA carriers was shown to be shifted towards higher recurrence score results. There is the Hadassah study, also ours from Bellinson, and also MSK, Memorial Sloan Kettering, have their own data, which presented by Mark Robson. So the study objectives of our study was to compare recurrence score distribution between BRCA carriers and the general recurrence score as presented in the general population, and to compare single gene group expression for the 16 cancer genes within the recurrence score assay between these two populations, and to evaluate the association between recurrence score, single gene group expression, and outcome in BRCA patients. So this is a retrospective study, and the study group is consecutive female breast cancer patients with BRCA germline mutation. They could have a node-negative disease or node-positive disease. All of them, of course, were HER2-negative disease. All of them, of course, had the oncotype test. And the test was performed between 2004 and 2015. And they received treatment in Rabin Medical Center or Hadassah Medical Center. And the general population control study group was the 800,000 excisional samples of the oncotype. I think it's a very impressive number. And now when we look at the study group, then the median age of the BRCA patient was 56 as compared to 60 in the general population. You can see that 80% had node-negative disease, and I must say that the nodal status distribution was similar to the general population. As expected, many of the study group had grade 3 disease, and something interesting, 40% had BRCA1 disease. So when we look at the recurrence score results, then the median recurrence score for the general population was 16, and the median score for the BRCA patient was 25. You can see the brown part in the graph. This is the BRCA bar, and this is the BRCA, and this is the recurrence score for the general population. And the recurrence score distribution shifted towards higher recurrence score categories, as you can appreciate. And then we investigated the results by menopausal status. The shift towards higher recurrence score was observed in pre- and postmenopausal study patients separately, irrespective of the menopausal status. You can see on the right hand side, you can see patients above the postmenopausal population. On the left hand side, you can see the premenopausal population. For the BRCA patient, we exactly knew the menopausal status because we opened all the files. Of course, for the 800,000 patients, we did not have the menopausal status, but we, as commonly used, we took the age, the cutoff of 50. For older, we consider them postmenopausal, and younger, we consider them premenopausal. So you can see that the results are irrespective of the menopausal status, and as we know, the BRCA patients are getting into the menopausal status because of BSO in earlier stage. When we looked at the recurrence score results by mutation type, then there was no difference, statistically difference between BRCA and BRCA2. And now the main part of the study, the single gene expression results. So initially we looked at gene by gene and we compared the mean values to the general population. And then we looked at the group as a whole. When I mean at the groups, there are the ER group, the proliferation group, the HER2 group, the invasion group, and some other genes. So you can see that in 12 of the 16 cancer genes, and in 3 out of the 4 gene group score, they differed significantly between the study patients and the database, the general database. And when we look, and it's something I think it's interesting, the estrogen receptor, the estrogen gene is actually, there is no difference between the BRCA patients and the general population. And when we looked at single gene expression by menopausal status, the statistically significant differences between the study patients and the database were mostly retained upon stratifying by menopausal status. Something I think is quite interesting is the fact that we found, and I will say that we don't understand exactly why, we found that the progesterone expression was higher in the premenopausal women as opposed to the postmenopausal women, and also in the node positive disease as opposed to the node negative disease. Why I say it's a little bit surprising, because progesterone is considered a good prognostic marker. And here, in the younger age, we found a higher expression of progesterone. Honestly, I don't understand it. I have a partial explanation, maybe it might be a partial explanation for the BRCA1 patients. We know that there is a correlation between the BRCA1 function and progesterone expression. BRCA1 acts on 2 levels, on the amount of progesterone receptor found in the mammary epithelial cells, but again, these are the mammary epithelial cells, and by controlling the expression of the progesterone genes. So it might impact the progesterone expression in the tumor itself. I don't know. If you have any ideas, then it is highly appreciated. Then what about treatments? Treatment received by recurrence score and mutation type. Overall, 46% of the study patients received chemotherapy. Treatment decisions were aligned with the recurrence score results. And then we looked at clinical outcome in the study patients with a median follow-up of 8.2 years. 9 distant recurrences were reported. No statistically significant difference in patient disease characteristics were found between the 9 patients with distant recurrence and the remaining patients. If you look at the recurrence scores of these patients who have developed distant disease, you can see any recurrence score, from recurrence score of 16 to recurrence score of 41. And if I look, well, these are very small numbers, of course, but if I look at these patients with distant metastasis and look at the low recurrence score, so you can see that all of them, the 5 of them, have not received chemotherapy, except 1 that have received CMF. And this makes you, well, again, this is a very small number, but this makes you wonder, maybe the threshold for BRCA patient should be different. Now, when we looked at distant recurrence and gene expression in a logistic regression analysis, a statistically significant association was found between the proliferation and invasion gene group scores and distant recurrence. You can see that the proliferation group has a great impact on odds ratio for recurrence. So what are the strengths and limitations of our study? First of all, it represents what we do in daily life, and this is very important. The follow-up is very long, I think, and of course we can't ignore the very robust control data set of nearly 800,000 samples. The limitation is the sample size of the study group, which is relatively small, and a small number of events, fortunately. So conclusions, I would say that BRCA carriers with ER-positive, HER2-negative early breast cancer have higher recurrence score results that could not be attributed to the menopausal status and stemmed from a distinct gene expression. Of course, now there is the question about the olaparib, the adjuvant olaparib. This, of course, has not been addressed in this study, but it might be that recurrence score may be a helpful tool also to decide whether to give olaparib. I would like to thank all the investigators, especially Hadassah, who gave their data, and Avital, of course, Genomic, who provided this wonderful data, and also the advocate from Clalit, who gave us legal advice. Thanks so much.
Two questions we have? 2 or 3 minutes? You can have 2 or 3 questions from the audience. Any questions? No? No questions?
I'd just like to say that thank you for doing this work and the torture we put you through.
Understatement.
We have a lot of interest from AstraZeneca, who makes olaparib, recognizing, of course, that they would like to sell more olaparib, but they're very interested in these data because being younger or older, but having a high recurrence score is not that common. And they're trying to understand whether women who have a score of 26 to 100 should automatically have BRCA testing. Because to try to enrich the population of patients for detection in a group that may not otherwise be tested. So they're very interested in your data and the other data published prior to try to enrich the number of women who would be tested who may not otherwise be tested.
Could be another study.